Dr. David Richardson is a glaucoma specialist from San Marino Eye. If he can come up to the stage, he is going to be talking about taking a look at the latest in glaucoma medications. So if we can just welcome Dr. Richardson. There you go.
All right, good morning. Welcome, everyone. So nice to be back in person. So attended one of the early GRF patient summits and was just amazed at the energy and the opportunity. So it's really good to be back here as a presenter this time. So let's go ahead and start. Let me see if I've got. So we'll be taking a look at the latest in glaucoma medications. Now, before we do that, just a brief, what is glaucoma? I'm sure that all of you have a sense of it, and you probably have a sense that we know what glaucoma is. The fact is that we don't really have a good definition or understanding of glaucoma, but I'm going to see if we can blow past that and focus on what we need to know for the medical treatment of glaucoma. So here's the eye. You've all seen images like this. And basically what we're going to focus on here is the front of the eye and the back of the eye. So the front of the eye, the cornea, the iris, the colored part of the eye, where if somebody says you have blue eyes, of course, they're talking about the iris. So essentially, most glaucoma medications work at that little space between the cornea and the iris, what we call the angle, or the outflow system. We can essentially think of the fluid produced in the back of the eye, in the ciliary body, being balanced by the fluid that's exiting the eye. And so essentially, if you don't have the right balance, the pressure can either be too high or too low, both of which are problematic. We need a kind of Goldilocks pressure. So if too much fluid is produced or too little fluid gets out, pressure goes up in the eye, just like the pressure would go up in a tire or a ball, and that then damages the optic nerve. Pretty much all of the medications that are available for glaucoma work by either turning down the faucet or opening up the drain. All right. Now, before we can get into the newer glaucoma medications, we need to actually study the old, right? Because they're a basis of understanding the newer medications. These are the classes of glaucoma medications that are available. There are actually more medications than classes because some of the classes have more than one medication available. So where should we start? Well, it turns out that we actually need to go back over 100 years to the Victorian era. The first glaucoma medication that was used was pilocarpine. Now obviously it wasn't packaged like this, didn't look like this, it was compounded by local pharmacists. Pilocarpine works essentially by stretching open the drainage system, and so it works by increasing outflow, allowing more fluid out of the eye. Okay. It actually predates the FDA, so it's grandfathered in. The mechanism of action we talked about. How well does it work? It works really well. Why don't very many of us, how many, I'll see a show of hands, how many of you are taking pilocarpine? All right, so one. Okay. Exactly. So this medication has been around for over a century, but it's hardly used even though it works well. And why? Because the side effects are horrible. Headaches, decreased night vision, increased risk of retinal detachment. Oh, and you've got to take it 4 times a day. So not very popular. It is covered by most insurances, but there's recently been some generic shortages, so it's been a little difficult to obtain. So let's fast forward. The next available glaucoma medication did not appear until 1954. This was Diamox. It was an oral medication. Acetazolamide is the generic name. This also works, this one works rather at the production of fluid. So Diamox decreases the production of fluid. Less fluid, pressure goes down. The mechanism of action we talked about, how well does it work? It works really, really well. but it also has a lot of awful side effects. When you take Diamox or acetazolamide by mouth, you can be lightheaded, tingling, metallic taste. There's even a very rare anemia that can occur that can be life-threatening. So this is not generally today thought of as a good long-term treatment, but if you had glaucoma back in the 1950s, pilocarpine and acetazolamide were the ticket. Just so none of you feel that you have to take copious notes here today, I do have some videos available online that go into greater detail in most of these medications. I put a QR code up there in case you want to get the link. I will have a link at the end of the talk as well. So 40 years later, we actually got a topical version of a carbonic anhydrase inhibitor. So essentially we thought, this is going to be acetazolamide or Diamox for the eye in a drop form. We won't have all of the systemic side effects. Won't this be wonderful? And Diamox works so well, this new drop should work really well too, right? Well, it turns out that the topical form of carbonic anhydrase inhibitors is actually the least effective of the current medications that we have. But, in 1994, it was at least an option. The side effects, not really too many side effects. We go from horrible body side effects of the oral form to just some stinging. But the dorzolamide does sting, and it stings pretty severely for a few minutes. The problem is this dosing. It really needs to be used 3 times a day. Now, some people can get away with twice a day, but it's really a 3-time-a-day dose. Generic is currently available, but the branded version, Azopt brinzolamide, which stings less, is not covered by most insurances. Okay. Again, if you want to know more, here's one source. It's not necessarily the most entertaining or the most thorough, but if you want a little bit more detail. All right, so to stay on topic with the carbonic anhydrase inhibitors, we moved forward 40 years. Let's rewind a bit. Okay, so other than pilocarpine, a miotic, and the carbonic anhydrase inhibitors, what was the next class that became available? Well, that would be the beta blocker class. Most of you are probably on a beta blocker, timolol. The other one that's commonly used today, betaxolol, which has fewer cardiac side effects, is also commonly prescribed. There are others, but they're less commonly prescribed. How do the beta blockers work? They work by turning down the faucet, so less fluid is produced in the eye. These were approved in 1978. They work really well. The problem is they have systemic side effects. If you've got high blood pressure and a high pulse, these are great. If you have low blood pressure or a low heart rate, then these are probably not for you. Dosing schedule, fantastic. You can really get away with using them only once a day. Oftentimes they are prescribed twice a day, but they're very forgiving if you take them in the morning. They don't work as well in the evening, actually. That's because the natural creation of fluid in the eye starts to shut down in the evening anyway. So any treatment geared toward reducing flow when the flow is naturally being decreased isn't going to work as well. Fortunately, the beta blockers are covered by all insurances, at least the timolol version. Betaxolol is not always as well covered. Again, more information if you want on the beta blockers. So 2 decades after approval of timolol, right, the FDA approved the first fixed combination drop. Now, what's a fixed combination drop? Fixed combination drop is basically 2 individual drops put together in one bottle, right? This actually required approval by the FDA, and it may not seem like that big of a deal. You've got 2 drops that are already available, but it means that you've got less drops to take, which means you're more likely to actually get all of them in your eyes. So when you combine a beta blocker and a carbonic anhydrase inhibitor, they both work by decreasing fluid production. How well does it work? Well, it works quite well because you're actually taking 2 of these medications and combining them. The side effects are class additive. What does that mean? That means you've got the side effects of the beta blockers and the side effects of the carbonic anhydrase inhibitors. So you get all the benefits of both, and you get all the side effects of both. The good news is that the fixed combination carbonic anhydrase inhibitor generic version is covered by most insurances. The preservative-free COSOPT PF, however, is not often covered. All right, so let's fast forward a little bit more. We're getting closer to today. 1996. 1996 was truly a time to celebrate for those treating and for those with glaucoma. Why? Because the prostaglandin analog class was approved. Okay, this was a brand new class. Not only was it a brand new class, but it was a brand new mechanism. Now, the prostaglandins work by increasing outflow, so basically opening up the drain. But the interesting thing about the prostaglandin analogs is they worked through a slightly different drainage pathway, the uveoscleral pathway. Okay, why is that important? Because in theory, if you take one drop, such as pilocarpine, that works at the conventional outflow, and you combined it with a uveoscleral, you could potentially get both. Now this is where the theory and the practice don't always meet. It turns out we didn't get the kind of double or synergistic effect from adding pilocarpine to latanoprost, but that really didn't matter because we really weren't using pilocarpine very much. How effective is a prostaglandin on its own? Prostaglandins are the most effective class other than timolol. So timolol, prostaglandin analogs, depending on which one you're looking at, pretty much neck and neck. The nice thing about these is they're also once daily. An early prostaglandin analog that was approved was twice daily, and primarily because of that, it just was never used very much. So in theory now, you could treat most glaucoma with a morning drop of timolol once a day and an evening drop of a prostaglandin analog. And that's actually what many, many patients are using, and both of these work very well together. Latanoprost, the generic, is covered by most insurances. The brand names, Travatan, Lumigan, Xioptan, a few others, are not always covered. And again, I go into greater detail in terms of the prostaglandin analogs in this video. I also have a separate video on specifically the side effects of the prostaglandin analogs, which fortunately are all cosmetic. Some of them desirable, some of them not so desirable. Okay. Now, what else happened in 1996? 1996 also saw the FDA approval of brimonidine. Brimonidine is part of a class called the alpha agonist class. Now, this class had actually been around prior to 1996 in a form called apraclonidine or iopidine, but really that was a drop that was most appropriate for use in the clinic, and although it was prescribed to patients, it was not well tolerated. So what's exciting about the alpha agonist class is that this one medication both decreases fluid production and enhances drainage. Okay. It was approved in 1996, same year as Xalatan, so again, a bumper year for glaucoma. Wonderful dual mechanism. It's quite effective, but it does have a high rate of allergy. So about 15% of those taking it will eventually develop an allergy to it. And once you develop an allergy to it, you really can't tolerate continuing it. The other issue with the alpha agonist class, brimonidine, is that it has to be taken really 3 times a day. Many can get away with twice a day, but it does work best 3 times a day. Generic brimonidine, 0.2%, is covered by insurances, but the branded 0.1 or 0.15 is not. You might think, well, don't you want the higher concentration? You get more for your medication. You don't, because the 0.1 works just as well as the 0.2, but has a lower rate of allergy. Okay. And again, this is not the prettiest image, but all right. So a decade later, what do we get? We get another fixed combination. So again, not as big of a deal as 1996, where we actually got 2 brand new medications, but every fixed combination is an opportunity to decrease the risk of missing drops. because if you miss a drop, you don't get the effect. So Combagan, which is brilliantly named combination of beta blocker and alpha-GAN, basically works by decreasing fluid production and enhancing drainage. So both the timolol and the bromonidine. As with the other combination drop, the fixed combination, you get the benefit of both, but you also get potentially the side effects of both. And it does need to be dosed twice a day at least, usually morning and early afternoon. Unfortunately, this one here, even though it was approved in 2007, is rarely covered by insurances still. Really takes insurance a while to cover things. A few years later, though, so we're getting closer and closer to today, and we're really getting quite a few options here. A few years later, there was another fixed combination. Now, by now, you might be thinking, oh, fixed combination, kind of ho-hum, this is not very exciting. Well, Simbrenza was exciting. It was particularly exciting to physicians prescribing medications. Why? Because this was the first fixed combination drop that did not have a beta blocker in it, all right? So this both decreases fluid production and enhances drainage, so combining the alpha agonist class with a carbonic anhydrase inhibitor class works really well. It has to be dosed 2 to 3 times a day, just like the carbonic anhydrase inhibitor itself or the alpha agonist itself. It's unfortunately not covered by most insurances, but the key thing here is no timolol, which means that anyone with a cardiovascular issue that risks too low blood pressure, too low a heart rate, can take this medication. Unfortunately, just like with the alpha agonist, bromonidine, it does have a high rate of allergy though. So about 15% of the time, this has to be discontinued at some point. All right, so combo drops are nice, but for almost 20 years, there was no additional class that was added to the glaucoma management until 2017. So 2017 was a year, just like 1996, where there was cause for great celebration. And so 2017, that's only 6 years ago. What entered the market at that point? The nitric oxide donator. All right, this is latanoprostene Bunod. Nitric oxide donators work at the drainage system. It opens up the drainage system, but using a different mechanism than the others. And we're still discovering just all the different ways that nitric oxides can help increase the outflow from the eye. Now, the first one that was brought out was not just a nitric oxide, it was a combination of a prostaglandin and a nitric oxide. It's approved in 2017, increases outflow by dual mechanisms. How well did it work? Well, a little bit better than latanoprost. So it wasn't a double effect, it was kind of like latanoprost plus. So not as exciting as we were hoping, but definitely an improvement. Dosing is the same as latanoprost, so just at night. Unfortunately, it's not covered by most insurances. So since you're only going to get a couple of points extra pressure lowering, for many people, it was a hard decision to make whether or not it was worth paying out of pocket, often a couple of $100s a month, in order to do this. But sometimes it helped people avoid surgery. So it was a great addition to have. My hope is that we will see future nitric oxide donators that are more effective than this one. All right, and there's a little bit of information about the latanoprostene Bunod. The real excitement, though, for 2017 was the introduction of the ROCK-NET inhibitors. So the ROCK-NET inhibitor class, which right now we only have one in the United States, Nitarsudil, though there are others elsewhere in other countries, it does seem that Nitarsudil works a little better than the ones that can be gotten overseas. The brand name is Ropressa. How does this work? It also works at the drainage system, but using different mechanisms than the other medications we have. So we now have multiple medications that work at the drainage system, but through different mechanisms. And because they're different mechanisms, there's the opportunity for potential synergy, right? So approved in 2017, improves the outflow, and I state here that it's conventional outflow system plus. What do I mean by plus? Well, it turns out initially we thought it just worked at what's called the trabecular meshwork, which is kind of the drainage grate in the eye. And fluid goes through the trabecular meshwork into Schlemm's canal, from there into the collector channel systems. And we thought, well, it works at the trabecular meshwork, and over time, it actually changes the trabecular meshwork, makes it more efficient, more effective. It was thought that if you remove the trabecular meshwork, as happens in certain surgeries, the effect of this medication would disappear, because that's where we thought it worked. But it turns out that even if you remove the trabecular meshwork surgically, you still get a beneficial effect from this. So we now believe that it works not only at the trabecular meshwork, but possibly downstream, as we call it, in the collector channel system. And if that's the case, this is a truly revolutionary drop. It's nighttime use. Actually, let me go back one. Nighttime use, so it's very convenient. What about the side effects? So the side effects are red eye and achy eye. And let me tell you that you need to be patient with this drop for two reasons. One is the aching is real, all right, and it's going to last for a week or so, but it does disappear. If you can be patient and you can push through the aching goes away. The redness resolves a little bit, but it never really goes away. Why is it worth pushing through if you need this or if it's prescribed for you? Because for most people, it will bring the pressure down by 4 to 6 points. And here's the interesting thing. There's now evidence that if you continue over time, you can continue to get incremental improvements in your pressure over 6 months, right? There's no other drop that we have available that actually has the potential to continue to improve the pressure over time. The problem is that most people don't get through, well, I don't know about most, but many people do not get through the first 2 or 3 weeks because they say, oh, my eye's sore, I can't tolerate it. But truly, if you can just push through, the soreness goes away. As far as insurance coverage, there are a lot of insurances that don't cover it, but this last year, a lot have come on. And so the coverage is improving, it's getting better. I fully expect in the next year or so, most insurances will cover it because it works, it's effective, and as a whole new class, it's a great thing to have available. Now, as you've seen here through this presentation, there tends to be a decade, 2 decades, all of these things between approvals. But amazingly, the FDA, only 2 years after approving Nitarsidil for use on its own, approved a fixed combination. This fixed combination is a truly wonderful combination because it combines latanoprost, the prostaglandin analog, which is one of the most effective classes out there, with Nitarsidil, this new class, both of which work through outflow, but through different mechanisms of outflow. This one, unfortunately, is not covered by most insurances, but again, my hope is that it will be shortly. And now we get to the most recent one. In 2022, September, so under a year ago, the FDA approved a new class of glaucoma medications. You've probably not heard of this one yet, Omlanti, because one, insurances are probably not covering it. It does work just like the prostaglandin analogues at the outflow system. Okay? It is what's considered to be a prostaglandin receptor agonist. Now, what does that mean? So the prostaglandin analogues work through certain receptors. They're proteins in the cell membrane. An agonist is something that, although it's not actually a prostaglandin, essentially mimics it. It works at the same receptor. So why is this a big deal if it's basically working at the same receptor? It's a big deal because just as everyone responds to certain medications in a class, some better than others, if you've got an analog that works at a slightly different place or binds slightly differently to the receptor than the prostaglandin itself, there's a good chance that those who are not fully responding to prostaglandins may actually respond to this class. In practice, how does it work? It works almost as well as a prostaglandin. Not quite as well for most, but again, for some people it will work a little bit better. So this isn't a huge wow, but it is an interesting addition, and with all the addition of new classes, it opens up the possibility that additional molecules will be developed within that same class that may work better, or that some people may tolerate, or just find works better for them. So again, unfortunately, this one's not covered by most insurances, and that's pretty much the standard for anything that's new. And by new, that's a definition in quotes. As we saw earlier, 2017 drop is still not covered by most insurances because they get to decide. But that's a survey of the medications that are available today. It's, I know, a little bit overwhelming when you see all of the different classes. The good news is that there are quite a few options available. The bad news is that you now know that we're just all plumbers up here. So anyway, I hope that you found this informative as both a survey of what's available as well as an introduction to what is new. And thank you for that.